We are live.
Good evening, everybody. I welcome you all to yet another iFocus online session. Today is 560th episode. Currently, we are in 35th module of Optics and Refraction session. Today, we have Mr. Swapnil Thakur from LV Eye Institute to enlighten us about optics of instruments, autorefractor, and potential acuity meter. Welcome, sir. To moderate today's class, we have Dr. Pratiksha ma'am. Ma'am has finished her MS from Maulana Azad Medical College, Delhi, followed by senior residency from Guru Nanak Eye Center, Delhi. Currently, ma'am is an associate consultant with Center for Sight Eye Hospital, Haryana. Previously, ma'am has worked as specialist ophthalmology in ESI Hospital, Haryana. She's a recipient of Champions Award at UC. Ma'am holds a distinction in medical training as well and has authored over 30 journal articles, given over 40 presentations and lectures at various ophthalmic meetings, both national and international level. Also, ma'am is a mentor for fellows and DNBs at Center for Sight Eye Hospital. Welcome, ma'am, and over to you for the introduction of our chairperson and speaker for today's session.
Thank you, Kritika. So once again we have Dr. Vijaya with us today as a chairperson of this session. She is scientist and low vision specialist at LVPEI Eye Institute, Hyderabad. She has a 36 years of clinical, academic, and research experience. She has done UG in optometry from Elite School of Optometry, PhD from Queensland University of Technology. She is postdoctoral fellowship at Flinders Medical Center. First Indian diplomate in low vision and fellow of American Academy of Optometry. He is conjoint professor of University of New South Wales School of Optometry and Vision Science. She is founder of the Mira and LB Deshpande Center for Sight Enhancement, LVPEI. She has trained more than 1,000 optometrists across India, published more than 110 peer-reviewed papers, 160 plus national and international presentation. She is former president, International Society of Low Vision Research and Rehabilitation, and chair Low Vision Group ARView. We welcome you, ma'am. So today's speaker is Mr. Swapnil Thakur. He is Bachelor's Optometry, PG Diploma in Optometry, Visual Sciences, FAO. Currently pursuing PhD in Optometry and Vision Science at Myopia Research Lab, LV Prasad Eye Institute, India, in collaboration with City University of London. He has 10 plus publications, book chapters, and various presentations in both national and international conferences, teaching undergraduate and postgraduate optometry students. He is reviewer of several peer-reviewed journals, International Ophthalmology, Ophthalmic and Physiological Optics, Clinical and Experimental Optometry, and TVST. He has received Professor Pruthapalli Ravindranath LVPEI International Travel Grant 2023 and Travel Grant for International Myopia Conference 2024. We welcome you, Mr. Swapnil. Over to you.
Thank you, Dr. Pratiksha. I'll share my slides. Dr. Pratiksha, can you confirm that if you are able to see my slides?
Yes, very well visible.
So good evening, everyone. So the topic which was assigned to me was how does we estimate refraction using automated technique? And in addition to that, the other gamut for the talk is what is really a potential acuity meter. So to begin with, I just wanted to discuss about the timeline of open field autorefractor and the history of open field autorefractor or the automated autorefractor is not very old. It just started in 1930s where we started to see technological advancement in the field of photodiodes, and then various types of LEDs came to the market, and the advancement in the computer displays, microelectronic processors, and so on. So when we look at the timeline of the autorefractor, the main part began in 1935, where the Collins developed the electronic refractometer, which is one of the first semi-automated refractor. But there is a catch that in 1940s, the World War started and then everything paused regarding all the optics. But following the World War II, we see many of the development in the field of autorefractor. Campbell new developed the concept of new autorefractor, followed by in 1960s we saw Boston Lom introducing new one of the first commercially available autorefractor, followed by several advancement in the field. And it was only in 1980s where we see more commercially available autorefractor, and then it uses become more common in various optometry and ophthalmology clinic. So this is the timeline of the autorefractor, and let me discuss about some of the key characteristic of autorefractor. This is slightly busy slide, but let me take you through some of the key points. So majorly all the autorefractors, at least now, which is available in the market, uses an infrared light which is reflected from the fundus. The advantage of using this infrared light was the pigment in the fundus, which is melanin, hemoglobin, xanthophyll, does not absorb the infrared light. So that's one of the advantage of using that. And the other advantage of using infrared was that it's the 90% transmitters through the various ocular media. But addition to that, using the infrared also had some disadvantages, because since it's not absorbed by the macular pigment or the fundus pigment, it generally scatters, and which can reduce the signals which is coming back from the fundus. Uh, Coming back to the second point of using what is the intensity being used in autorefractor, various studies have mentioned various products uses various types of intensity. For we don't have fixed intensity for what for the infrared light. So I have just mentioned that it can range from 0.5 to 1.5 watts per radian centimeter square. We don't really have a disadvantage of using those various range of intensity. The third point which I wanted to mention here is the accommodation and fixation control. Some of the talking specifically about the closed field autorefractor, it has a factor of proximal accommodation, because now the target is now inside the instrument and it's really close to the eye. So it might influence the outcomes of the refractive error, which we do through at least closed field AR. But some of the new advancement in the autorefractor has inbuilt accommodative relaxation, and then the stimulus which is being used in the autorefractor could somehow compensate for the accommodation. And then in the present situation, we cannot really know about what is the degree of accommodative fluctuations happen when we measure refraction using the closed field ARs. And the fourth point is the vertic distance. It varies depending upon what is the product we are using in terms of autorefractor. It can measure refraction at corneal plane or spectacle plane. There are other factors which can influence the measurement of autorefractor, mostly the pupil size. Some of the autorefractor has been limited to the certain range of pupil. If that goes beyond that, then we might not get a reliable measurements, especially during when we use pilocar or somebody has accommodative spasm. So there might be we feel a limited scope of, at least for the closed field autorefractor. So coming back to what are the principles of autorefraction, I will not go into the nuances of uh, uh, every principle of the autorefractor, but I'm going to discuss about two of the most common which we are using currently. The first is the closed field autorefractor, which is based on sinus principle, and the other one is the open field autorefractor, which is based on image size principle, and I will be discussing both of them one by one. So starting from the closed field autorefractor, I know that most of us know that the closed field autorefractor has internal fixation target, and which can be viewed via the fogging system which is inbuilt there. But things to note here is that although there is a presence of fogging lens system in those closed field autorefractor, we cannot fully rule out the influence of accommodation on the refractive error measurement we do from the closed field autorefractor. Coming to the principle, it's based on Shiner's principle, and going back to the history, it was coined after the Christopher Shiner's, which was he was the physicist and astronomer, and he has many discovery. And one of the greatest discovery he had was he found that the optic disc is located on the nasal side of the fundus. So that's one of the discoveries of him. Coming back to the what is sinus principle, when we go back to the our undergrad optics book, Thomas Young has conducted one experiment on double slit experiment where he wanted to study the nature of the how wave propagates. So taking the foundation from Thomas Young's experiment, Sinus develops the sinus principle. So what really is this principle means? Actually, when we simplify this principle, it's a sinus disk. Basically, aperture. There are two apertures where the light is splitted into two parts, and then we see where it focused, depending upon whether the eye is myopic or emmetropic or hyperopic. When you see example, the figure on your left hand side, this is a case of a myopic eye where a point source image is there, and then a convex lens, condensing lens is there, and then we have a sinus disc with a two aperture. In a case of a myopic eye, we get to see that it's focused in both from both the apertures. Light rays are focused in front of the retina. But how do we measure the myopic refraction? There is slight movement in the lens system, and thereby the now both of the light rays from both the apertures are now focused on the fundus, and then we get to see the refractive error of that individual. In cases of astigmatism, at least by theoretical point of view, the principle becomes more complex, where the sinus disc needs to be rotated to the principal meridian and then do the measurement. But since all the things are now auto measurements, we don't know how exactly this happens, because we get to see we can easily measure both spherical refractive error and astigmatism. So this was some of this concept of using sinus disk was bit old and has been used in old refractometer, where we get to see two apertures. But now in new autorefractor, instead of sinus disk, they uses a two LED light source where they form a different image at different plane, and then continuous movement of the Badal system and the lens, we get to estimate the refractive error. So that's the bit of difference between what the old autorefractor had and what new autorefractor is giving out. So let me show you one tutorial video of how we really do close autorefractor.
So this is a closed field autorefractometer where we can measure the refractive error. And here the force field, the target will be inside the instrument, that is very close to the eye. So let us see how we do the closed autorefractometer now. Place your shin. And now we'll make it clear by moving back and forth, and we will again press 4 to 5 times to get a reliable value. If the Myers are not clear, we'll ask the patient to blink to make the Myers clear. So now we are getting the values. It takes some time. Open your eyes bigger. Okay, same way we will do with the left eye also. We'll make the Myers clear ask the
One thing
patient
you
to
would
blink
notice that we will
and
be
tweak in the same
continuously
way.
giving instruction to the patient while doing the measurement. So that's bit of important side when we
Okay,
are
now
using
we
an
will print
autorefractor.
it. Print the values. So we are getting the central refraction value of the right eye and the left eye. Here we can only measure the central refractive value of the eye.
So after we saw the video of how what is the procedure of doing a closed estimating refractive error using closed field autorefractor, let us just discuss about what is the comparison of the values we get from different types of autorefractor, and then what are the how can we compare that to a retinoscopy, and what is the repeatability of the autorefractor based on different principle. So this is the evidence coming out from one of the in-house experiments done by Padhi et al. And they compared the autorefractor based on different principle with the retinoscopy. If you focus on the top panel, so that's basically a bland Altman plot where the x-axis is your average of the two spherical average of the two instrument, and the y-axis is your difference between the two instrument. So this clearly, if you focus on, so this dotted lines are the limits of the agreement. If you clearly see that there is a huge difference between what the measurement we obtain from retinoscopy and the open field autorefractor, and if you focus on the range ranging from -1.5 -2 to 3 plus 3 diopters. So that much significant difference we can get at least from when we compare the closed field AR with the retinoscopy. The second, the last two is comparison of photo screener, which is based on different principle, and the IC, which is from Orolab. What is more common here is that the variability between the retinoscopy and the autorefractor did remain consistent throughout the type of autorefractor, and the range remained similar. What's even more important to see is that in the below panel, when we focus on what is the repeatability of the autorefractor, again, the same Bland-Altman plot where the x-axis is the average of the two sessions and y-axis is the difference between the two sessions. So here we see that when we repeat the measurement with the instrument, the measurement can be variably uh, between 0.75 to +1 diopters. So that's the range we can get when we repeat the measurement. And then the similar variation can be seen for the other autorefractor based on the different principle. So one of the major conclusion from this paper was refractive error measurement using different autorefractor, even though they are based on different principles, show minimal bias, and then short-term repeatability is good. But relatively, so the point to focus here is the large limits of agreement when we compare to the retinoscopy. So the second part is that one of the major disadvantage of using closed field AR is that we cannot really rule out the role of accommodation, especially when we do dry refraction. So in the market, we have open field AR, which has a very different design when we compare to closed field AR. So the design of the open field AR eliminates accommodation, and then in contrast to the closed field AR, where we do monocular measurement or monocular field of view, the open field AR provides a binocular field of view. And if you see the fixation targets, there is no specific fixation targets to at a specific distance. So we can keep target at any distance, given distance, and then we can measure refraction. So the main use for this open field AR, at least from the myopia point of view, we do peripheral refraction with this. We can assess accommodative response at various viewing distances. And some of the models of open field AR can do dynamic measurements as well for the accommodation. So when we go by the principle, in contrast to the closed field AR, which is based on sinus principle, the open field AR is based on image science principle. What really is, if I want to simplify this, there will be one LED with a in front of that there will be a lens and then annular stimulus and then Badal system. So basically what this principle does is that it will have a disk and then it will measure the image size of the disk of the stimulus, and then based upon the image retinal image size of that stimulus, it will calculate the refractive error. So for the uncorrected hyperopia, the how it estimates, because the image size is larger, and then that's how it estimates the uncorrected hyperopia, and then opposite is true for that. So there is a contrasting difference between the principle of both of the autorefractor. So let me show you how we generally do autorefractor in our myopia clinic.
So we will be learning today about the open pod refractometer. This is the open pod refractometer. It has an open wheel we can see here, and the examiner or the patient will not be having a target in front of them. We have an open field here. So the patient will be seen directly through this open space on the wall that is placed here. This wall is at 3 meters. Patient to keep her chin on the chin dwell and asks her to focus on the star that is there or at the F to capture the central refraction. So now you have to come and look to focus the eyes to take the refraction values. So here we can see the eye, the right eye, and we can see the Myers here. Between at the centers there is the cross. We have to make it clear and then we have to press it. After pressing, we can see the number of times the refraction values are being captured. 6 to 5 is okay. So refractometer not only measures the central but also the periphery. So how we will measure the periphery now, we will show you. You can see here on the wall we have multiple targets. The center one is the central target. We have a 10 degree, 20 degree, 30 degree. Is horizontally and also vertically. So the patient will again keep her chin. We will ask the patient to now look at the 30-degree mark that is done on the one there. So we can see that the eye have turned into some degree, that is the 30-degree target. So the Myers are at the central position, but still we will place the cursor on the center of the pupil and we'll measure it. We'll again take 5 to 6 clicks at the same position. It's in the right eye, and next again we will go at the left eye. Again we will focus. So here we are measuring the left eye nasal meridian. Okay, pause. Now we will print it. So we got a right eye temporal value, that is temporal 30 degree, and left eye nasal 30 degree. In the same way, we will repeat the other side of it.
So this is the simplistic process of how we measure central refraction, which is much more common and then we are much used to. But the major advantage of using open field autorefractor is that it can give you the liberty of estimating the peripheral refraction. So there are two key points which I want to emphasize on while using the open field autorefractor. So if you focus on this image, let's imagine that here at below there is a open field autorefractor, and then we have 3 targets. So how do we fix that target? What is the calculation? So the central target is easy. So we can fix the central multi-cross at 3 meters of distance. And how do we place the eccentric targets? Let's imagine that we want to place a 30-degree target at nasal and the temporal side. So the formula for it's a simple formula to calculate what is the distance between the central target and the peripheral target. So we basically uses a Pythagoras formula of tan theta, which is perpendicular by base. The perpendicular values is, let's say, 3 meters, which is the distance between the open field and the central target, and the base we have to find out, and the degree we already know, which is 30 degrees for in case. So base with this formula, the base is 1.8 meters, which means that we have to place a target eccentric to the central target 1.8 meters away. So that's how we calculate the distance between the two eccentric distance between the central target and the eccentric targets, and then place the fixation targets. So the other point I want to emphasize here is that how do we calculate the relative peripheral refraction? So let's imagine this is an arbitrary value where the central refraction is -3, -1, 180, and the spherical equivalent is -3.5. In the temporal 30 degrees, we get -1, -1.25, 165, which gives a spherical equivalent of -1.62. And in nasal 30 degree, we got a -4.5, -1, 170, which in the spherical equivalent it's -5. So how do we estimate what really is relative peripheral hyperopia and what relative peripheral myopia? Relative peripheral hyperopia is when there is a less myopic refraction when we go towards periphery. So if you see this temporal 30 degree, we have -3.5 in the central, but in the temporal 30 degree, we have only -6.2, 1.62. So that gives us a relative peripheral hyperopia of 1.88. And then opposite is true for the relative peripheral myopia, where in the central refraction, we get -3.5, but in the periphery, in the nasal retina, we get -5. So that's how we estimate that what is the magnitude of relative peripheral hyperopia and what is the magnitude of relative peripheral myopia. So what is the repeatability of this open field AR? There are several papers on this. This is one of the papers which have reported the repeatability of what is for the open field AR for the central and the peripheral refraction. If you recall what I have shown earlier about the repeatability of the closed field AR, it ranges between -0.75 to +1, even more than that. But if you see this, the repeatability of the open field AR, it's very tight, and it ranged between -0.25 to +0.25. So here you see a major disadvantage of using an open field AR instead of closed field. So this is about central retina, but there are the figures which are on right hand sides are on the different locations. So let me give you an example of what's the repeatability of when we do uh, peripheral refraction using open field AR. If you see the limits of the agreement, it range between -0.5 to +0.5, and that's on 20 degrees of retina. But important thing to note here is that when we go more eccentric, the variability increases. And now let's take an example of a 40-degree nasal retina. The variability increased from -0.5 from 20 degrees to now at least approximately -1 to +1. So that's because the eccentric we go, there are more astigmatism, and then it may cause a variability in the estimation of peripheral refractive error. So recently we also compared what is the difference between a retinoscopy and open field AR. Again, I wanted to recall that if when we the earlier studies have compared the retinoscopy with the closed field AR, the difference between the two techniques was ranging from -3 to +3. But when we compare the open field AR's values with the retinoscopy, the variation was there, but the variation was slightly less compared to what we have seen for closed field AR. So variability, what we have seen for open field AR with the retinoscopy was within the -0.75 to 1 +1. And as we go to the eccentric location, we get to see more variability there. Okay, so why we are really talking about peripheral refraction and why it is more important? This is another evidence from in-house study where they have estimated relative peripheral refraction in different uh, types of refractive error and myopic subgroups. So In the first figure, the x-axis is your x-axis is your location of the refraction. So minus on your left hand side, it's minus 40, which means 40 degrees nasal retina, and then plus 40, which means 40 degrees temporal retina. And the y-axis is your relative peripheral refraction. There is a contrasting difference between what we get to see in myopes compared to other refractive error. In myopes, we get to see a more asymmetric relative peripheral refraction, where the temporal retina has more relative peripheral hyperopia compared to nasal retina. We get to see relative peripheral myopia. But this asymmetry in the relative peripheral refraction was not present for a hyperops and a emmetrops. So that's for the horizontal meridian, but for the vertical meridian, we don't get to see such differences. When we focus on myopic subgroup, the higher degree of myopia we get to see more relative peripheral hyperopia. For instance, in this figure, moderate myopes have a more relative peripheral hyperopia compared to low myopes. Moving on to the what's the difference between the closed field AR and the open field AR. I found one of such studies which have reported the difference between the two types of autorefractor. If you focus on the figure, the A0 versus the C, which is the comparison of closed field AR with the retinoscopy under non-cycloplegic refraction, we get to see more myopic refraction when we do closed field AR and then compare it with your retinoscopy. When we compare the open field AR to a retinoscopy, the difference still there, but it's still significant, but we don't get to see a overestimation of myopia there. And then this trend continues with different age groups as well. So that's the one message from this part, is that the when we want to ensure that there is a no or minimal influence of accommodation in our refractive error assessment, we want to prefer open field AR over the closed field AR. So that's the part of what's the auto refractor, what's the update on auto refractor. The second part is on potential acuity meter, which is less commonly used in the clinic. So what's that? It basically gives you the expected acuity, and then it's basically used in the what I can know is that in the cataract cases, and then we can estimate what can be the visual acuity after the cataract removal is done. And then it can also estimate the visual acuity where it's difficult to measure visual acuity using a conventional Snellen chart or logMAR chart. So that condition can be a large refractive error, corneal vitreous opacity in cases of hyphema, posterior capsular opacity, and so on. So what's the feature of the PAM? It's much simpler to what we get to see in the open field. In the PAM, we have a point light source. There is a prism to divert the light, and then we have a plus 12 condensing lens, which can focus the beam of light on the retina directly, and then we have a visual acuity chart. So we can we can use the PAM in range of refractive error from -13 to +10 diopters, and then acuity can range from 2020 to 2400. And then the advantage is that we can estimate the visual acuity in the cataract subjects as well. The procedure is pretty much simpler. We should do in dark room, dilate the pupil to get more retinal illumination. Some of the models of PAM is connected to slit lamp, but some are separate to the slit separately present. And we can adjust the refractive error. And then as the patient reads the last line, it can gives you the what can be the potential visual acuity in that individual. I did not get, interestingly, I did not get any tutorial video on PAM, because in LVPEI we generally don't get to see PAM use. But I looked for some of the evidence on what can be the how reliable can be the potential acuity meter comparison to the other methods which are much simpler than that. So one of the studies have compared the application of potential acuity meter with the pinhole test, and that if you see the conclusion on your right hand side, the conclusion is that the PAM was more accurate than the pinhole test in the predicting visual acuity of uh, for the cataract surgery. So the other study compared the potential acuity meter with the usually illuminated near target card, and interestingly it reported that the both PAM and then illuminated near card reported same difference, reported same visual acuity. So that's my last slide.
Hmm. Thank you, Swapnil. That was actually very elaborative and very good presentation that we could have in this topic. I think we have few questions. Krutika, do we have questions?
Yes, ma'am. No questions as of now on YouTube. But questions from our side, ma'am. Will AR have any difference? I mean, we know it will have difference, but how different will it be when we measure it in a dilated pupil and undilated pupil?
Dr. Kritika, if I go back to that table, the highlighted one is for cycloplegic, non-cycloplegic condition. But when we compare these under cycloplegic condition, when you compare the retinoscopy versus the closed field AR, the difference was 0.207, which is although significant, but does it clinically meaningful? We don't know. But of course, when we do cycloplegia, the difference between the retinoscopy and the AR decreases.
Swapnil, is it just because of cycloplegia? Because in one of the slides you showed that even the pupillary size affects the AR outcome. So if the patient is just dilated, maybe just opaque, will that also affect?
Yeah, that might affect, but we don't know because there are various models of autorefractor, and then how does it considers whether it has some correction factors for the pupil size. So that's something which we are not we are not aware about. So at least I cannot confirm. Maybe Dr. Vijaya can comment on this.
So, so here it is. So there is a difference, at least I don't know. So autoreps have been there, right? Like Swapnil said, they've been there for ages now. But the overdependence on autorefs has become something that I have been seeing now, maybe in the last decade or so. And earlier, at least at LVP we didn't, right? And now, from what I see, I think I would rather do a cycloplegic retinoscopy under cycloplegia, and then compare and have a AR done under cycloplegia. And from what I see, I do not now. What is the retest repeatability? What is the like he said, the limits of agreement that are there, and what will you consider clinically? At the end of the day, if you tell me, I will only believe or probably trust the retinoscopy manually, right? And so I don't know. I'm just trying to think loudly, but I would rather. But we've seen differences between the dry AR and between the cycloplegic AR. And what we do is we confirm, we do a retinoscopy, make sure that, and now retinoscopy also you can have people with varied experience, right? But people who have sufficient experience, retinoscopy, and retinoscopy, and that will do the job actually. But your retinoscopy skills should be good. So yeah, so that is in a nutshell an answer. But yes, there is a difference between dry AR and cycloplegic AR. And which one should you consider? I will always say, please do retinoscopy, and then check if it is close enough. But just going by AR, I don't think makes any sense. Busy clinics, yes, but
And nowadays,
you
yes.
prescribe based on that? No.
And ma'am, nowadays we have so many like multifocals and trifocals. Now, if they have residual error, like how do you do refraction in such cases?
Why? What is the problem in doing
In
retinoscopy?
the multifocal IOLs, ma'am. Patient with the multifocal IOL.
Why is there a problem in doing retinoscopy? I don't know. I'm asking this.
The IOL has different power in the different circles. So which one do you consider like for near, for distance? Like AR doesn't give a good value for in such cases. No?
I don't know. I don't. At least I don't think I'm seeing those patients I don't see those patients, but I would assume that you would. See, now again, you're talking of an age group that usually has meiosis, right? And so that age group has meiosis, and my gut feeling is that I think you get only that central 2 millimeters, right? So probably you're refracting only that central 2 millimeters, and unless you have good refraction skills, more often than not, I'm not sure if people are really refracting properly also. At least that's my perception.
Just
And
to
because
add some, yeah.
one second, Supani. And because these trifocals and all of this, they give good acuity at varied distances, right? That's why we are putting in these trifocals and all of this. So patients are able, vast majority are able to compromise on many of those things, because not everybody is a pilot, okay? And so that's why they wouldn't complain. But there'll be a very small section which is probably that fussy ones who at every distance they want to be able to, maybe very, very, very small proportion. So at least in the practically, will it make a difference? I am not sure. So even if you didn't refract and if you just left them alone, I think the job is done, because the trifocals are doing the job. At least published literature on patient-reported outcomes, right? And it has shown that the satisfaction with outcomes following extended depth of focus, the trifocals, any of these has been fantastic. Except for those, like I said the other day, the negative dysphotopsias, the glare, those starbursts, those bother them. But so it is the quality of vision, it is not the quantity of vision. And these are two different things. So it is the quantity of vision which they are okay with, but probably the quality of, and you have questionnaires to assess quality of vision, right? You have starbursts, you can ask for halos, you can ask for different things. So it all depends on what is the, so if you have a very patient ear to your patient, then you know what they are telling you, right? And so more often than not, I think they are talking about quality of vision. They are not talking about quantity of vision. At least this is what I think. This is my perception. So it could be very different. And now, sorry, Swapnil, you wanted to say something.
I just wanted to add, Dr. Pratiksha, that when we do over refraction over, at least for multifocal myopia control lenses, we get to see some difficulty with the retinoscopy reflex, because the concentric rings are there. So that was something which I wanted to add.
Yeah.
So maybe, like
Right.
he's saying, it may be challenging to refract. And I would assume that, and he's talking about myopes, young, these are all young. So they'll have pupil diameters that are pretty larger. So it could be a challenge there. But my assumption is with the age group, that cataract that is with meiosis that is usually there, you'll get to see only that central 2 millimeters. and it's not very easy to refract anyway. You'll see only that single thing. So it's very challenging also to refract. So unless that person has enough refraction skills experience. So, and like I said, most patients are happy, just unaided and with excellent outcomes. They are not complaining. So even if you left them just like that also, nothing, no problem. They're very happy because people are looking for spectacle independence. And that is one of the, so this is something that has been reported in the literature. What are your reasons for undergoing cataract surgery? Okay. You ask them. And at least the low, maybe the high myopes, one, then moderate hyperopes, okay? And spectacle independence in that age group is something that is paramount to them. They say, I want spectacle independence. And you will see this, right? And they're very happy not looking for their glasses after cataract surgery. And it is not the blurred vision that bothered them. It is just the spectacle independence. And let me tell you, patients are extremely happy that they've got rid of their glasses. And they don't want to see N1 or N2 or N4, right? They are reading newspapers, which is pretty N10 kind of a size, N8, and that's okay for them. They're happy with that. So I think that is what it is. And having said all of that, is refraction important? Of course, it is important. But is it a crime to leave them alone just like that? I don't think so. I think they're pretty okay, rather than do some wrong refraction and give them something else. If they're not complaining. So if there's this saying, right? If it ain't broken, don't fix it. So if they're not complaining, please don't do anything with them. They're happy that way. You don't want to rock the boat. So yeah, you don't want to do those things.
Ma'am,
Yes.
about
I'm not sure if that is the answer to your question, but that is my perception.
Definitely,
ma'am, one more question, ma'am.
Arey,
About the hyperopic shift that we see in autorefractor post cycloplegic effect. Does the different type of cycloplegic drug have different significant change in hyperopic shift caused?
I
As in
would.
cyclopentolate has less, atropine has more, something like that, ma'am.
Swapnil Garu. Swapnil will answer.
I just got logged out from the portal. Can you repeat your questions?
So the type of cycloplegic drug, does it have any difference in the amount of hyperopic shift that is caused on autorefractor?
Yeah, I mean, what I expect is that when we use atropine ointment, we get to see more hyperopic refraction
Yeah.
compared to tropicamide or at least cycloplegic eye drops.
Is it a significant difference, sir?
Clinically, I'm not able to. I will not be able to tell, but yes, expected that the atropine will have a greater effect.
Swapnil, I just want to add, I think that's my personal, maybe my personal thing. I have noticed that even the tear film, like with dry eye, also affects your refraction outcomes, especially in AR. Sometimes when we
Yes.
ask the patient to blink and again go for an AR, it is absolutely different. Ma'am, you want to comment on this?
No, it is the height of the tear meniscus. Yeah. So so my assumption is, again, this is just because you're asking. I'm just thinking loudly. So it is the height of the tear meniscus, and I think because of the aberrations that can cause, right? And so because of that, there could be induced refractive error and all of this. So that's why, like Swapnil showed, no, so frequent blinking, and then so all this comes with some experience. And so for a novice, they'll not know all of this. And so when you send somebody who doesn't know, they'll get one value, okay? Then you send somebody who knows something, you'll get some different different value. Now you don't know which one to
Yeah,
be, okay? So I'm like, okay, now which one is correct? Then you will do
yeah,
refract, then we'll do retinoscopy, then we'll see,
yeah.
acha, this may have happened or something like this. So, but that's a very nice point that you raised. It's wonderful because I'm just thinking loudly to say, okay, the height of the tear meniscus probably that could influence, at least may not be much, but whatever it is, I don't know.
Yeah.
Yeah, even some of the AR has a message written on the screen of the instrument that ask the patient to blink twice. just to make sure that there is a good amount of tear film.
And also, Swapnil, what is the effect of like in post-refractive surgeries? How does the AR, do you think, how does it works? It give some difference?
Uh, if retinoscopy varies, so we expect that the values for the autorefractor will be also not that much reliable.
Ma'am, you want to add? Like, ultimately, it is the retinoscopy.
Yeah, that's what I'm saying. So everything, so it is all surrounding your skills, and that doesn't go away, you only get better with time. And there is nothing like using your hands, right? And so I think I belong to that school of thought that says that you should sharpen your skills in refraction, nothing like that. Retinoscopy, and retinoscopy, and you get excellent with it, but many people shy away from it, and they think that that is something that they can get away with. But I say that if you don't know that, then you cannot do anything, right? It's meaningless, anything. So that strong foundation is so important to build that. Anything after that is a bonus, right? But if you can't fix that, then there's a problem. Then you should not be in that field and call yourself an optometrist. And so I've said this. I've said this for all my life, and I say this, and yeah. So
That's true, ma'am.
yeah, and you get better with time, and you learn, and you should take pride in learning that, because it's a skill, right? And unless you practice and unless you do these things, then otherwise machines will take over your life, right? It's like AI. They say, AI is only 70%, 30% you have to use your brain, still you have to use your brain. But here also it's the same thing, right? If you just go by just AR, you're done with it. So then where is your skill? So you do, and then you can confirm, that's not a problem. I'm not saying that. But without having done that, and then you just do that only, that I think is injustice. So at least that's what I think. So I have
Ma'am, we have three
whatever
questions on YouTube.
whatever we said, mota moti is refraction is important, microscopy is important.
Yeah, that is the main thing.
I know, that's what I'm
Yeah.
saying. And
And nowadays, ma'am, many of us are losing those skills actually with the upcoming all the
that is
machines.
what I'm saying. And technology is taking over. Absolutely. I'm all for technology, but not at this cost, where you lose your skills, right? What is the use of that? Because technology will keep changing. Your skills won't change. Your hands won't, they will not leave you, So I
Yeah.
don't learn that, so that that is, and let me tell you, it's a skill which you can lose very quickly, because if you don't do it, and then it
Yeah.
looks very alien to you, it will look very new to you because you've not been doing it. And yeah, so that is all that I can tell. But people get carried away by this fancy equipment that is being marketed, and so much so for that technology. Yeah, sorry, she wanted Pratiksha. Sorry, she wanted Kritika wanted.
Krutika?
Yes, ma'am. The question, shall we take up the questions on YouTube, ma'am?
As long as I can
Yeah.
answer.
Yes, ma'am.
Or
The
Swapnil can
first
answer, I don't know.
The first question says, which is a more reliable instrument when we compare between ray tracing based refraction versus open field autorefractor?
I couldn't find the comparison study, but if I say at least what we are using for the myopia clinic, in the myopia clinic as well as in for our research purpose, is open field, and it has a resolution ranging from 0.01 to 0.025. So that's the precision which at least open field gives. As far as the ray tracing wavefront abrometer based abrometer is concerned, I think that would be also equally effective when we compare it with the open field AR. So that's my assumption, but I have to look into the literature what's it says.
Ma'am, any take on this? Any additions, ma'am?
No, not really, because I think that because the abrometer, I really had to think, but abrometer, I think I do not know if there will be a difference, but my assumption is you'll get more details in the abrometer, which you will not get in the
Open
uh,
field layer.
yes. That's my feel. That's my perception. In terms of the, I think so. I don't know. See, I don't do these things much, so I would not be able to answer. Just to be honest enough, yeah.
Ma'am, for the second question, how reliable is AR in cases with corneal aberrations post-refractive surgery? Though we like in cases of autorefractor where we get to the wavefront sensing as well. So how reliable is AR in such cases? If we talk about higher order aberrations, ma'am.
I don't do it, but my feeling is that AR depends, right? So AR post refractive surgery uh, should 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 be okay. This is like again the same thing, right? So you have dry eye and all, which is very common, right? Post refractive surgeries, be it more probably after PRK than after LASIK and all of that. And so I think that because of the tear meniscus, which we discussed and all of that, there can be an issue. So, but I do not know if there should be a problem with AR post-refractive. I do not see a problem. I don't know. I do not know if Swapnil has a. Swapnil, you want to say something?
No, Dr. Vijay, nothing to add here.
No. Yes, because see, again, I don't work in that space. But from the research that we have done in terms of the patient reported outcomes and all of that, that we've looked at about close to maybe 1,500 refractive surgery patients, both PRK and LASIK. And we didn't do AR though, but in the clinics they've done. I think they've done. So I'm not sure. I haven't done it myself, but my feeling is I don't know, except for all the dry eye things and all of that, I don't see a reason why there should be a problem. As long as you've given the right instructions and the tear meniscus and all of that is taken care of. If there are these dry spots and all of that, that can cause that aberrations and all of this, but otherwise, no. At least that is what I think.
So a comparable corneal aberration profile when we compare with AR from abrometer, ma'am. That's what. Okay, ma'am. And the next question is for open field AR in different light conditions, will the refraction value vary?
Yes, of course, because the pupil size will decrease or vary depending upon the light condition, and there are papers which have measured the refraction under different light condition, mesopic, scotopic, photopic, as well as in different wavelengths of the light, such as blue, red, and there are differences depending upon the condition what we measure for the refraction.
And so may it be any type of refractor. If it is a closed field AR or an open field AR, it does vary with the pupil size. The pupil size gives a different reading for the refraction that we get, isn't it, sir?
Yes. So when we go by the principle of open field AI, it's based on image size principle, and there we get to see more importance of pupil when in comparison to a closed field AR. I mean, the role of pupil is slightly limited in closed field, at least. But in open field, because that, I mean, it can vary. I mean, it can vary depending upon what condition it is, and then based upon the principle itself. So we get to see more. I mean, we assume that the importance of pupil size will be more in open field cases.
Okay, sir.
More questions, Krutika?
That's all, ma'am. That's all.
So I think it was very back to basic class. Although we keep using AR day in and day out, but still there are so many doubts and so many queries which keeps coming in. And after all, as ma'am pointed out, the main thing or the backbone remains the refraction only,
Retinoscopy.
the
Yes, ma'am.
retinoscopy basically. So it was a great learning with you, ma'am. Thank you, Swapnil. It
Oh,
was a fantastic, elaborative presentation. We
oh,
learned a lot, uh, and
का
the
भूला
journey still
शाम को
goes on.
शाम का भूला घर को आया kind of a thing. This is that सब कर करा के we have concluded that retinoscopy and your hands
Retinoscopy.
hands are the best.
Always an
Definitely.
upper hand.
Nothing can replace that.
I know, I know. I'm like, yeah, I think so. And I always say this, retinoscopy, the origins have been retinoscopy for any of these, right? And so yeah, so that is something I think that all the postgrad students should know, that unless you have practiced that and unless you have learned that and you have mastered that, it's very difficult. And because anybody can fool you otherwise. And that is something that yeah, because see, in the practice, wherever you're going to practice, you're going to work with a team, right? And you should know at least that much, that people should not take you for a ride to say, okay. And yeah, so you should always know that you can always check. You don't have to maybe refract every patient, but you should be able to check and say that, look, I think this is not correct. So can you please redo? I will check, kind of a thing. So people know that you're around to check, and they'll be very vigilant. That's all I'm saying. So that way, you're very sure that you're not making any errors. So I think just to save your skin. So that is why it is so important.
And in fact, nowadays, ma'am, people are going for progressive lenses and
Yeah,
they cost a hefty amount. And just
absolutely.
prescribing anybody on the basis of AR, and when they demand the precision, that is,
Yeah,
I
that's
think
what
that
I'm saying.
needs,
Yeah, and patients are becoming demanding these days because
yeah.
not take anything lying down, right? And so you got to be very careful about how you do things, what you do, and then again, uh, what to say, an acid tongue can damage things. So yeah, so if you can talk very sweetly, even doesn't matter, but that also is
Mhm.
chanta. But the thing is there. So yeah, that is why, yeah, like you said, with the progressive addition lenses these days and all of the latest IUL technology that is there, refraction has become even more important, because
Yes.
you can't little this side, that side, anything. And there are people who are very finicky and very fussy,
Yeah.
right? And 1 degree this side, that side. Well, my
Yeah.
husband, for example, if you change his axis even by 2 degrees, no, he'll make such a big fuss. So, and to refract him is so difficult. It is not easy. Even 1, 2 degrees, no, it'll be like, wow. I'm like, wow. I didn't know that even 2 degrees can make this much difference. This I didn't know, but yeah. So yeah, so like you say, it is very important. Yeah, the axis, the degree, the orientation. So all
Yeah,
this.
even the working distance and
Correct, correct.
yeah.
And all this comes from experience, and it doesn't come just like that. So yeah, so I hope that at least the audience gets that message, that refraction is so important. It's a skill that needs to be built over time. It's not overnight, and that much regard for retinoscopy.
Yeah. That's a basic and that's a bread butter also.
Yeah, absolutely, absolutely. And I cannot overemphasize on that. It's so important. But we hope that our audience enjoyed this session. And thank you
Yeah.
so much for doing this wonderful job. And
Mm.
very nice. And
Mm.
yeah, so we've had 2 sessions. So the next
Mm.
one is on next Wednesday by Lavanya. And she's somebody comes in with a lot of experience again. And so she's all geared up and she's waiting to speak on next. I asked her, she said she's all prepared and she's ready to speak on next Wednesday. So we'll connect again next Wednesday. Just send the details, no problem.
Yes. So let's
Lovely.
call it a day.
Yeah, lovely,
Thank you,
lovely.
Yes, ma'am.
ma'am.
Lovely, lovely.
Thank you, Swapnil.
Thank you, ma'am. Thank you, sir. Good
Bye,
night,
Kritika.
everybody.
Good
Bye, ma'am.
night.
Good night.